Good afternoon, everybody, and a very warm welcome to this next instalment of our paediatric mini-series, which today focuses on physiotherapy and supporting your child at home. I'm delighted this afternoon to be joined by Kay Ganguly, who I will formally introduce in a little moment. But for those of you who have not seen me on screen before, my name is Carmel Gallagher, and I'm the Paediatric Client Liaison Manager at Irwin Mitchell, based in the Leeds office. As I mentioned before, this is part of our mini-series, which over the last few months has looked at a range of issues that have been identified by parents and carers. And as the slide on the screen shows you right now, we are here at number 4, looking at physiotherapy. The next in our series will take place on the 10th of September, and that will focus on education and healthcare plans. Obviously, there have been a number of changes to that area of work, and I'm sure many of you will be interested in that. A few points of housekeeping before we move on to the main body of our presentation today. First of all, many thanks to those of you who have posed questions prior to joining the event today. We will be looking at some of those later on in the presentation. Anybody who wants to raise a question can do so at any point during the presentation, and the question mark button should appear on your toolbar in the middle of your screen. All I would ask is that you put your name or an email address linked to your question so that we can identify you should we need to do any follow-up support with your question. Unfortunately, we're not able to answer individualised questions this afternoon. We will deal with those separately via email, either by myself or by Kay. But what we will be able to do is provide a general response to familiar topics or similar topics that people raise with us during the afternoon. Also, just to let you know that this event is being recorded, and that live recording will be sent out to you via email. That will probably arrive in your inbox by the end of this week or the beginning of next week, so do keep an eye out for that. And it will also be available via the Irwin Mitchell YouTube channel. So without further ado, let me introduce my colleague Kay. Kay joins us today from her home office, but Kay is a highly experienced physiotherapist, clinical director and consultant physiotherapist at Healing Touch Physiotherapy, and Kay has worked with Irwin Mitchell for a number of years supporting children and families affected by serious injury. A very warm welcome to you, Kay.
Thank you, Carmel. Thank you for introducing me. Hello and welcome, everyone. And thank you for giving me the opportunity to speak today and share my experience on how to support children with neurological injuries and complex disability. I would like to thank Irwin Mitchell for inviting me today and ask me to speak to you all. I'm really looking forward to this event. Can I have the next slide, please? So my name is Kay Ganguly. I'm a consultant clinical practitioner. I specialize in pediatrics and neurological physiotherapy. Healing Touch Physiotherapy is a small specialist service. We are based in Leeds, and our clinicians have expertise specializing in pediatric neurology, adult neurology, and also vestibular rehabilitation. I'm really hopeful that I'm going to share some useful tips and guidance with you all today, so you can go and use it for your child or for your client, whichever capacity, and help them through the process of recovery. Can I have the next slide, please? So the key learnings. What are we going to talk today? We're going to understand the causation and presentation of neurological movement disorders. It's important to understand the clients that we see and the children, the way they present, why do they present in a particular way, and what is the cause for this. So we're going to talk a little bit in detail about that. We're going to talk about the long-term implication and the factors to be considered when devising a therapy plan for these children. We're going to talk about how to help them develop and maintain their skill set within the home setting. During this critical time, it's important that we enable and support children and maintain their existing skill sets, and not just maintain, but also help promote the age-appropriate development. And understanding how to facilitate the learning process and how to help them achieve their objective goals is absolutely crucial. We're going to talk about appropriate equipment and support structure, how to facilitate their body symmetry, how to facilitate the postural care plan so that they're able to achieve and move forwards within their rehabilitation process. And interestingly, we're going to also talk about some red flag signs and how do parents or families or even the care team know when to raise concern, and when is the time when you realize that there is some significant physical deterioration, and what's the time when you will actually seek medical advice. And of course, a very big topic, which is spasticity management, we're going to touch base as well. Next slide, please. So every injury is different, and when I say that, what I mean is it's likely that two children have similar injury. Probably the brain scans will show the similar sort of injury and impact. Part of the brain involved is as well quite similar. However, they can present extremely differently. They can be quite different from each other in their clinical presentations, and that's why there is no one strategy that will fit all. What we do is we assess individual clients, and based on their specific needs, we will formulate a plan and a treatment plan and their goals, which is very specific to that child. And then obviously that plan is delegated to the care team, to the families, to the rehab assistants, whoever is working with this child. So it is very, very specific. So brain injuries are like snowflakes, and no two are the same. It's important that we understand this. Can I have the next slide? Thank you. So just to touch base on what causes the brain injury, before we actually talk about the management plan and how we support these children, I think it's useful to know what are the causes of brain injury and how are they caused. So birth asphyxia, we call it hypoxic ischemic encephalopathy, HIE. Very, very prevalent in newborn babies, or this is an injury that happens at birth. Umbilical cord around the fetal neck is one of the causes. Prolonged labor is one of the causes. And what it actually does is, during this process, there is oxygen deprivation to the brain, and the part of the brain which is deprived is damaged. And what these children typically present when they grow is a diagnosis called cerebral palsy. And this is one of the commonest cause of birth injuries leading to cerebral palsy. The second one is infection, like meningitis, sepsis, encephalopathy. These are actually infection that affects the brain tissue, actually layers of brain, obviously treated with pharmacological management. However, as a result of the tissue damage and the brain tissue damage, these children can have functional deficits when they grow up, can have acquired brain injury as a result. Then we have malignancy, which is actually cancerous growth in the brain tissue. Now, brain tumors can be anywhere but the site of the tumor is important, because when a tumor is generated in any part of the brain, the removal of the tumor is obviously managed, and the treatment plan is managed by the surgical team. What is important for us to understand the site of the tumor, because based on where the site of the lesion is, the adjacent structure, the adjacent brain tissue is likely to be damaged, either with the pressure or even in the process of taking it out or debulking of the brain tumor, there could be injury. And what is important to understand is around this area, when the tumor is taken off, what kind of injury that we are going to cause as a result, and what will be the functional deficit. And hence this is a careful consideration that is taken by the surgical team when they operate on that. For us to remember is the site of the injury is directly linked to what the function of the brain that facilitates that functional movement. So I think that's an important area to understand. Then we have the traumatic brain injury, which is divided into concussion, contusion, and skull fracture. Quite common concussion in adolescents or young children, contact sports, football, rugby. What happens is if there is a direct impact to the front of the head, the brain being a loose organ within the skull moves forwards and backwards, could be an impact in the front of the brain or the back of the brain. We call it concussion. Contusion is a direct blow to a particular part of the brain on the skull, which is, again, causes the damage to the brain tissue and a brain injury. And we have a skull fracture, which is a traumatic injury, which can, of course, cause damage to the underlying tissue. We could have hemorrhage as a result, subarachnoid hemorrhage. There are various other clinical implications. Can I have the next slide? Thank you. So the leading causes of TBI in children and adolescents of 0 to 14 years of age. And I've just tried to demonstrate what do we normally see and what kind of injury is more prevalent. So as you can see on the graph, falls is typically about just over 50% of the cases are as a result of fall. Struck by and any other events is roughly about just over 30%. Motor vehicle accidents, about 10 to 12%. Assault, again, about 10%. And other injuries, unknown causes, about 15%. Now, interestingly, the falls and assaults, which is quite often a shaken baby syndrome or other physical abuse, are also the most common causes of TBI in infants, toddlers, and preschoolers. And TBI, which is secondary to velocity injury, like motor vehicle accidents, bike accidents, or sports injuries, can occur more in a little bit grown-up children, adolescents, and teenagers. And this clearly highlights the risk-taking behavior in adolescents and teenagers. The frontal lobe of the brain, which is responsible primarily for executive functioning, like planning, organizing, and understanding consequences, and understanding risks. This part of the brain doesn't develop till a child is 21 years of age. And hence the RTA and other sports injuries or bike accidents you see more prevalent in teenagers and young adults. It's an interesting concept, but it's worth highlighting this. Thank you. Can I have the next slide? So how do the injuries present and what do we see? So obviously we have talked about a little bit about the causation and what causes brain injury. And this will talk about the presentation. What do we see in our clients and how do they present? Quite commonly, spasticity. And in simple words, spasticity is resistance to movement. So if I'm trying to move a joint through a range, and if the movement is not smooth and if there is resistance to that movement, we call it spasticity in medical term. Children who are brain injured, quite likely they will present with spasticity. Either it can be in the one side of the body or it can be in all four limbs. Uncontrolled epilepsy and motor delay. Now, epilepsy is another quite a big area of within this brain injury client group. And epilepsy can be divided into just absent seizures. It could be a grand mal epilepsy, it could be a tonic-clonic epilepsy. What is important again here is to understand that every time a child goes through an episode of seizure, there is some element of brain damage that is associated with it, and hence there's recorded motor delay associated. So what is crucial for the families and the care team or the professionals to understand, that make sure that the epilepsy is treated. There is a referral made to the consultant, the neurologist who is involved, and there is medications in place. Low toned, again, these children, they present quite floppy, so they could have difficulty in holding their control, in sitting posture, in transition from lying to the sitting, or even in standing, or even holding their balance. They are significantly low toned. They would need supportive orthotics to help them self-support. Then we have a dystonia. Now these children present, they have a range of fluctuating tones, so they can be at sometimes quite low tones, the other times they can be quite stiff and rigid, so they have through the day they can fluctuate quite a lot. And some children within this category, they can be quite severe, and they present with excessive spasm and dystonia, and we call it status dystonicus, which is a medical emergency. And if that is the case, there will be difficulty in breathing. They will almost go to a state of spasm with difficulty to release that kind of movement. And if that happens, obviously this is a medical emergency. Please do get in touch with your medical team for further advice. Hypermobility, this is a condition, again, some brain injured children do have hypermobility. Their joints can be taken to the extreme range. Now every joint has got an anatomical range. And we know, for example, an elbow can be moved from 180 degrees to about 30 to 40 degrees. If I can extend the elbow beyond 180 degrees, if somebody goes into 120 or even further, then obviously there is an element of hypermobility. And as a result, what happens is these children they lack proprioception. They don't quite feel the joint and the approximation of the joints. And they're quite sensory seeking, these children. Again, we support them with adapted sensory garments. We support them with splints, just to make sure we support the anatomical position so they can mobilize and do the functional activities. We have another range called, classify them as ataxia and balance problems. Now we have cerebellum, which sits just below the brain at the bottom, and it actually controls the balance and coordination. If there is a damage to the cerebellum by any reason, or the involvement of the cerebellum, then we have a child presenting with ataxia. So they're quite wide-based gait. They can be quite unsteady. The balance is uncontrolled. They need supportive garments. They need supportive orthotics to support themselves. But a lot of targeted therapy to help them and help their brain regain the connection and learn the control. The coordination can be quite affected as well, these children. One-sided spastic weakness and hemiplegia. So if your right hemisphere of the brain is damaged, you will normally have weakness, prevalent spastic weakness on the left side of your body, and vice versa. If your left hemisphere is damaged, you will have a right hemiplegia. Very often the hemiplegia presents with spasticity, and they are weak on that side as well, and hence we call it spastic weakness. These children will typically present with one-sided being quite tight and maybe asymmetrical as compared to other side. They would need splinting, orthotics, adapted garments, so that they are able to maintain their posture and maintain symmetry. Then we have spasticity in the lower limbs, which is diplegia. It's a type of cerebral palsy where these children have got tightness and involvement of the lower limbs more as compared to the upper limb. So they are relatively functioning okay with their upper limb and the control. They might have problems with the fine control, but their upper limb are relatively better off than the lower limb. Lower limbs are typically very tight, spastic. They have crouched gait pattern, so they walk with their knees knocking almost together, very often on their tiptoes because the ankles are relatively tight. Again, these children need orthosis, they need adaptive garments, they need splinting, footwear modification, and of course a postural management care plan, working closely with their physiotherapist. And then we lastly have paralysis of the both legs. It doesn't quite fall under the category of brain injury. Some can have paralysis, but more often in spinal injuries where you have lower spinal injuries, people present with paraplegia, which is paralysis of both the legs. Can I have next slide, please? So how are the children coping? Because now we are in the pandemic where children have not been to school for over 6 months now. If we are fortunate, then they can start in September. But what do we normally see in these children? So some children are doing extremely well. They are engaging in telehealth consultations, and they are engaging with a therapy plan with their therapist. They're utilizing the extra time that is available to them because they are not attending school. And they're engaging well with the electronic devices. These group of children, they like to see them on the screen and perform because they quite like that visual input, and they engage really well, and they are making really good progress. And we have quite a big client group who have actually excelled during this lockdown period. They have done enormous work at home, supported by the clinicians, and they have really done well. They are enjoying the slow-paced world, and they are enjoying the fact that they're not in a rat race. They don't have to get up in the morning, go to the school, will stay at home, be homeschooled, and do your therapy and excel. And then we have the other group of children who are unfortunately having some anxiety due to social isolation, and they're having to cope with the uncertainty. So they do not know when are they going to meet their friends, go to the school, get back to the routine. And the other problem we're seeing is as well, children, they find the complex visual stimulus or the busy environment of the screen really difficult to cope with. So they have vestibular issues with focus and concentration, and bright screen is difficult for them to engage in. They're causing video fatigue. And as a result, they haven't unfortunately engaged in lot of physiotherapy intervention, and unfortunately there is some physical deterioration in this set of category of clients, and there are some health challenges we're facing. Next slide, please. So I thought it will be quite nice to just talk about remote consultations and what really happens. What do we expect in these consultations, and are they really beneficial? So what happens when you are booked with your therapist to come on a screen and have a consultation? What do you expect? So what we do primarily is we do a subjective assessment. So we will ask you about your child. We'll ask you some background, some information, what sort of therapy they have had so far, what other equipment they are using, what splints they're using, any relevant background that will help us devise the plan will go under the subjective assessment. And these can be very well be done over a screen because it's just a chat over screen, and we gather information while we're having a chat with you. The next one is functional assessment, and which falls under the category of objective assessment. So obviously, because we are doing this over a screen, we rely heavily on what we see on the screen. So we will ask you, we will just observe how your child is sitting, how are their balance looking like, how are they walking. We'll assess their joints. We'll pick up little things like whether their knees are hyperextending. Basically, we call it in our therapy world, we call it movement screening. So we kind of screen their movement while they're performing, while they're moving, while they're transiting from the floor to stand to sit to chair, walking, whatever they're doing, that part of the assessment. So how it is working at the moment is we will have a clinical triage. So when the new referral comes in, we're going to do a clinical triage and say, go with the virtual approach first, which is obviously guided by our professional body, just to minimize the risk of face-to-face contact. In that virtual first approach, these are the things that we will talk about: subjective functional assessment and movement screening. And basically, we're going to formulate a plan. We support our clients and integrate awareness and learning to them. So in the process of doing that, we actually step into your reality and we see what are the actual day-to-day problems are and how we could mitigate these problems and how we could support your child and make sure if any virtual advice could help. So if something like a stretching plan can be put in place, or if a particular postural plan that is beneficial, we could do a video plan for you. Your therapist will send you a guidelines or a toolkit where you can click on a link and it will show a video, so you could perform that with your child. We enable clients to do a self-assessment. So we'll give you a tool where you would be able to assess your child on your own to see whether they are making any improvement, or whether they are just maintaining, or whether they are there is some deterioration. So I think that's quite a useful tool for you to have. And then obviously we motivate and use support, help reframe the perspectives. The other thing to consider is, when we see people face-to-face, when we assess clients face-to-face, we use obviously outcome measures, which helps us devise and understand whether there is progress and whether it's documented progress. And these outcome measures are really crucial to justify how the child is progressing, or to measure rather. So if we had to assess somebody face-to-face, we use a wide range of outcome measures. CPIP is one, which is cerebral palsy integrated pathway, measures joints and range of motion, and then categorizes whether you are at a low risk or a moderate risk or a high risk category. There are other functional measures as well that we use. There is a body symmetry assessment that we do. We assess the body symmetry of your child, so we'll be able to tell at the end whether there's any asymmetry and what kind of positioning and postural management is appropriate for your child. Now that face-to-face contact is not possible, some of these outcome measures cannot be carried out. Of course, some can be done with some observational outcome measures. However, you couldn't actually physically assess a child. So what would your therapist do? How would they really measure the outcome and whether there is any progress? So I think we are going more towards the functional assessment. So for example, we use a measure called activity-specific balance confidence test. So there is it's a questionnaire that is given to the client. I think this is more for a little grown-up children, not for very young children. And what we ask them, there are about 16 items in this ABC scale, and questions like, are you able to walk around the house, and what is your level of confidence? So you might say, well, I'm only 50% confident about that. How confident are you doing up and down the stairs? You might say, well, I'm only 30% confident because I'm not too sure, I am a bit overbalanced. So we have like walking indoor, walking outdoor, walking with or without assistance. So there are about 16 items here. So this is something that could be done for virtual assessment. We could send this to you. You fill it up with your child, and we're going to score it at the end. So although I have not seen the client myself, but I can still measure their progress using the functional tool. There are other simple functional tools like how confident or how many times could you transfer yourself from your standing position to the floor and back. How confident do you feel? Or how many sit to stand from the chair you could do in 60 seconds. These are just some examples of how we can record progress without having to be with the client. And there are a range of vital balance tests and single leg stands and other tests. And these can be, again, done remotely. All we say is stay with your child or have a carer with the child in case they're overbalanced or then they need support, then there is somebody to help.
Okay, yeah, let me just come in there for a minute. I think that's going to give a lot of parents a huge amount of reassurance for you to have so detailed, in such a detailed way, being able to explain how assessment and ongoing goal setting and measuring is able to continue in the virtual world. I know that many families have experienced less access to therapists over the last few months. Many of them may be reporting to us that they haven't seen a therapist, but this gives them a real insight into the likely way in which their physiotherapy needs are going to be assessed, measured and reported on in the future months, isn't it?
Indeed, indeed. And we sort of, as therapists, years and years of working within this area, we have actually never explored these other ways of doing. Of course, we always have a functional tool that we use, but we relied heavily on the other established ways of measuring, like, you know, as I said, CPAP and other, where there's a direct measure and direct involvement of, and you visualize and you feel the joints. But unfortunately, we are forced to go more towards this side because we are a little bit impaired of doing, you know, functional actual physical assessments. We have been doing some, but you know, it's quite limited. It has to be really carefully risk assessed. So I think we are exploring. It's a learning curve for us as well.
Yeah, absolutely. And just a reminder to anybody listening live that if they have any questions that they want to put to either myself or Kay, you can do that at any point throughout the presentation, and there will be an opportunity at the end to review those. I think really what I'm picking up from what you're saying, Kay, is that, you know, a lot of the parents and carers that we work with are very used to already taking the lead role in the delivery of their child's physiotherapy program. And what you're saying here is that is likely to be the way that it continues for the foreseeable future, with therapeutic input at the right and appropriate times. Absolutely,
yeah. As long as you have a backup of a clinician and a therapist, and they advise you, you know, this is your plan, and delegate you the plan until you go for a review and they review that, you are okay to carry on with that. And obviously I will talk about the red flag signs in the further slides, how to identify when to get in touch with your therapist.
That's great, thank you.
Can I have the next slide? Thank you. So what is really interesting and important to understand is be brave enough to be bad at something new. And it's quite important to understand that for us, everybody wants to be doing everything perfectly. And everybody wants to be perfect. But however, your first step couldn't be perfect because you are making a new change. You're trying to do something which you haven't tried before, and it is extremely difficult. And for a child to be trying something new, it is extremely overwhelming. It is difficult for them. So really reassure your child and really help them make that first step, because that first step is the progression, is the step forward to the progression. It doesn't have to be perfect. Next slide. Okay, so this is the little tool that we use, and a little tool that we give to our clients and families to then understand when is the time where you decide, well, actually, no, there is some physical deterioration. When is the time you get in touch with your therapist or your consultant or your medical team, whoever is in your support network? So does spasticity cause muscle tightness or stiffness and limit functional activity that you were able to do previously? So if you were able to stand up from a sitting position with support, and then sit back with support, this is just a simple functional movement from sit to stand. And are you able to do that? If you're not able to do that for whatever reason, there is either spasticity or there's muscle tightness which is causing it. That is a physical deterioration. It could be anything. I could be comfortably walking in my garden for about 5-10 minutes and then come back. And if I can't do that now for whatever reason, that is a deterioration. That is a time when you need to see, why am I not able to do this? Is that there obviously has to be an underlying clinical problem, and we don't expect you to identify that, but we expect you to raise it with your clinical team, because they are going to intervene and they're going to find out why you're not able to do that. There will be clinical indicators to suggest after the assessment that there is obviously a muscle tightness, or you're weaker, or there is some intervention that's required. Is muscle tightness causing you to limit or others' ability to carry out your personal care tasks? Now, simple thing like changing of continence pads. If it is getting more and more difficult for your carers to work with you and help you with your personal care, that's something that you need to raise it with your therapy team, because it's likely that you're either getting very tight with your hamstrings or your inner thighs are getting extremely tight, spasticity is really developing. That's the time where you need to raise those concerns. Could be things like you're struggling to put your sleeves through, your arms are getting really tight, you're unable to extend your forearm and your elbow. That's again a functional limitation. It's a red flag. Muscle tightness, is you able to, your muscle tightness that prevalent that it reduces your ability to stretch or position your joints. So if you're not able to unable to straighten your knee, or your ankles feel relatively tight, that's the time that means you are going for tightness. And skin integrity is quite a big topic, and a lot of children who have got complex needs and who are wheelchair users have got tissue viability problems, and it is quite significant, because the nutrition plays a big role, but it's important to understand that just not nutrition, body symmetry plays a big role in tissue integrity. If a child is asymmetrical, if they have got scoliosis, if they are rotating to one side, if the bony prominence are quite prominent on one side as compared to the other, and if they lay in bed in that asymmetrical position, it's likely that they're going to have tissue viability issues and develop pressure sores on those vulnerable areas which are exposed. So what I suggest is skin integrity is maintenance of a child, and a skin integrity is a combination of postural care and of course the pressure relieving mattress and other supports that you would give to the child. So but body symmetry is absolutely important, and use a supportive sleep system to make the body symmetrical and keep them aligned at night plays an absolutely massive role. Ongoing pain. So is your child suddenly complaining of ongoing pain and discomfort, and they are not allowing you to touch a particular part of their body? Say the wrist is getting really tight, are they not letting you stretch it, not touch it? That's the time where you need to raise it. And digging off nails into the hand. So what happens is, as the spasticity kicks in, the elbow goes quite stiff into flexion, and the long finger flexors, they go really tight, and you come to a point where your almost fingers are digging into the base of your palm, and it's so difficult because A, it's absolutely uncomfortable, but B, it's really difficult to release because it's really difficult to stretch the forefingers sometimes, and children are really sensitive. So before actually it goes to that phase, you really need to raise that concern. If you see your child's wrist or hand and fingers are getting tight, get in touch with your therapy team. We will normally refer you for an assessment. We use a lot of supportive splinting, static splinting, dynamic splinting, or even like second skin and other DMO. They are the soft lycra splinting. There are various ways of working on it, but you need to make that choice, and you need to get in touch with your team. If you have an independent therapy team, then yes, get in touch with them. If you do not have an independent therapy team, get in touch with your NHS team. Quite often they work on episode of care. So if your child has been discharged from the NHS, get in contact with your community therapy team. They will open up a new referral, because this is the time where we're seeing a lot of children having lack of therapy and lack of orthotic intervention. There's a lot of deterioration that we're seeing during this time. And if you ever identify any of this, this is the time to pick up the phone and make that call. Can I have the next slide? Thank you. So spasticity management, another interesting topic. So your healthcare, as we identify that a child has spasticity, and the spasticity affecting the functional day-to-day activities, your healthcare professional will help you identify the need for a follow-up. So they will tell you, well, this is the time where actually you need to get in touch with your consultant, you need to get in touch with your neurologist or your therapy team, so that they can offer that advice and support. Quite often, if you're going to be getting in touch with your neurology team into the NHS. They are currently offering just telephone consultations. Their new referrals is quite limited at the moment, but they will give you a telephone consultation. They'll identify and review the assessment, and let you know what the next plan of action is. Enable practitioners to carry out community visits. Some community services are carrying out some face-to-face contact with suitable PPE. Some of the interventions that we use for spasticity management, Botox injections, these are actually muscle relaxants which are injected into the targeted tendons, which are tight. And as a result, we have a phase of about 8 weeks, 4 to 8 weeks, where the muscle is relatively loose, if you like, in simple words. And what we do is we maximize that phase when we are sort of eliminating spasticity temporarily, and we put the child in extensive postural regime during that time. So a lot of stretching plan, NMES, which is the neuromuscular stimulation, to strengthen the opposite muscle group so that we get an active stretch. We put them on splinting, so that's the Botox care. And then, of course, your medical team will give advices on pharmacological treatment and intervention like baclofen and diazepam as well, as a treatment for spasticity. And we use a lot of online resource, so develop awareness and knowledge of families of how to manage spasticity, and how to support them and help with the physical management and advice. Next slide, please. Okay, so key intervention. How do we, basically we talked about how the children present, what are the red flag signs, and I think it's important to understand how do we manage these children, what are our strategies of planning treatment around them. So we offer postural care management, which is managing their posture, managing their joint range of motion, strengthening the targeted group of muscle, helping them to facilitate the functional movement pattern, and in a simple word, just limit the abnormal movement pattern. We call it atypical movement pattern, which is non-desirable. That's the part of our management goal. We use suitable orthotics. They are splints. They could be static splints. As you see on the top, there's a little picture of splinting and orthotics, where it's just a static splint where the arm is just placed in the splint and strapped so that we just maintain the length of the long finger flexors and the wrist. We also have dynamic splint, which is the picture at the bottom, which is a blue shelf. It's a dynamic movement orthosis. This is typically used in people who have weakness or paralysis of one side, more often in stroke kind of clinical picture, where somebody has difficulty in extending their fingers. And if there is difficulty in extending the fingers, these orthoses will have spring-loaded extensors. So they are able to, you go and reach a grasp, so they are able to approximate the fingers, and the difficulty is actually release. So they say, pick up a target, take to the point where they need to release it, and they just let go of the control of the hand, if you like, and the spring does the opening of the fingers. And then this is actually the more repetition you do, carry on, you develop understanding of how the movement pattern is, and hopefully that leads to motor learning. So the more repetition, the better it is. Then we use other positioning system like seating system through the day. There'll be postural seating. We do nighttime positioning, which is positioning the child at night, as I say, as a part of their posture and maintaining their tissue viability. And the daytime positioning, you see there's a little picture on the left corner of the screen, and they are this company called Symmetric It, and they do a wide range of positioning systems that could be used in the classroom for the children. So because sometimes being in the chair all day is not quite suitable. These children need change in posture, so they can be the position in the lying position, or a little upright sitting position, or semi-reclined position, or even in prone position in their tummy in these positioning. So they are maintaining their body symmetry throughout the day, even while at school. And then we have the walking frame and standing frame, which is used in school or home or any other setting as well. We also use trikes. So these are like active movement patterns. So a child who is able to use a trike will be supported with a harness or a chest strap, so that they are well supported and they can be facilitated with the leg movement, which is great for strengthening the lower limb pattern. And there's another option, Motomed, which is a static bike, which can be used indoor if somebody is not comfortable going outdoor, which has got a function of passive and active function. And then we have supported practice, and these are like passive functions. So movement of the joints through a range passively, supported by the care team, by the family, whoever working with the child. So we devise a plan so that the family could support the child, make sure that the joints are moved through a range during the day. And of course, safe handling procedures. And if a child's handling procedure during this time, if you haven't seen any professional, again, your child has probably grown in size, in length, their needs have changed, probably their moving and handling plan needs a review as well. Make sure all the equipment that is used for moving and handling, like overhead ceiling tracking or a mobile hoist, or the slings, they are all reviewed as per the LOLA check requirement that is required. Because we have seen a lot of families who have actually found it really difficult to get somebody out to get the assessment done, but also with COVID restriction, things are quite difficult. But yes, if there is a problem with moving and handling, if you think you're finding it really difficult, this is the time you need to get in touch with your therapy team. NHS, get in touch with your NHS team and open a new episode of care. You know, they will be more than happy to help you. And lastly, what I like to say is, disability may affect children, and their exercise tolerance might be affected as a result. How much they participate in the exercise session obviously has to be very adapted for these children, and we need to consider the risks that is involved. However, rarely it's the case where exercise is ruled out. So exercise is applicable for everyone, and exercise is a medicine. And we need to cultivate the concept that exercise is not just required for your physical well-being, but also for your mental and emotional well-being. So it is absolutely crucial for everybody to be involved in some form of exercise. Next slide, thank you. How do we facilitate our approach? So collaborative working and building up relationship with your healthcare professional, therapist, and case managers, whoever in your professional network that help and support your child. Autonomy and accountability of your own health needs. And I think this is so important, because we're there to help you. Your medical team and therapy team is there to help you. But obviously, you know, we need you to take that accountability. And as I say, we will help you with a range of tools, but you're the person who is going to see your child every day. You're the person who will raise any concerns. And then, of course, we are there for support. And journey of recovery, resilience, and tenacity, and which loads and loads of families have shown during this time. They've managed to homeschool their children. They have managed to do the therapy for them. They've managed to do everything that otherwise would have been done at school or nursery. So very good work there. Ask for help as required, as we are here to help, and make your own sensible choices and seek for medical advice. As I say, we need to embrace a facilitation mindset and be creative and flexible. And of course, stay connected with your MDT team. Next slide. So recovery is a process. It takes time, it takes patience, it takes everything you've got. And I think for us, it's important to understand that there are numerous success stories of the children and young people with effective collaboration of the teamwork. And we hope that the benefits of these changes will persist in the years to come. next slide. And if you have any questions, I'm happy to answer.
For me, that key intervention slide, I think, is probably sort of the standout piece of learning that a lot of families will take away with them today, because it helps them to identify precisely what the support needs of their child is or are, and how they can communicate that with their physiotherapists.
Definitely. Definitely. And I think, as I say, you know, accountability is important because, you know, we are there to help you, you know, but we need the concern needs to be raised, and we don't live with the child. So obviously either somebody working closely with the child in the family or the care team, as long as things are being highlighted, we can come and put that advice and offer the support.
Yeah, absolutely. So let's have a look at some of the questions that have come through. And actually, the first one is one that you did make reference to earlier in your presentation. What advice would you have in supporting a child through a rapid period of growth?
Okay, that's an interesting topic. Obviously, as I say, children haven't been to school from March to now. So extremely likely children who are growing every day, within this 6 months phase, they would have had some growth spurts. Now, how do we, there are two areas that we need to be really careful about when we are assessing a child with growth spurt. A is the musculoskeletal system, which is their bones and joints and their muscles. And then you have the neurological system, which is your brain and the spinal cord, and actually the whole neurological system supporting the body. So children during this phase, say about 11 to 13 years old, all the children, they have active growth plates, which is, they are like active inflammatory growth plates, which is at the top and like your femur bone or your humerus bone. And they have got active inflammatory process going on because it's the time they're actually ossifying. So the cartilaginous growth plate is actually turning and fusing into the long bone. And this is the time where children are likely to have inflammation around the growth plates with any injury. So a lot of children who are into sports or very active, they can have a slip femoral epiphysis, which is the top of the head of the humerus has a growth plate, and sometimes it can slip. It's a medical emergency if it is not treated well. If it is quite a severe case, they are treated with screws, or it could be treated with physiotherapy management. You could have similar in the knee joint, quite likely in children who are involved in sports, football, rugby, that kind of activity. You can have, Osgood-Schlatter's disease, or in the ankle, is severe ankle. So that's just looking at the musculoskeletal side of it. But then you have the children who have got underlying neurological problems, and spasticity obviously cannot be eliminated because that's governed from the brain. And if there is a brain damage, there will be influence of spasticity. But the children, when they are growing, their bones grow much faster than the muscles. So you have a child suddenly shot up because they had a growth spurt, but however, the muscles are not as compliant. They have not grown at the same pace as the bones. So what it causes is sudden tightness in the hamstrings, long bones, all the postural muscles. So sometimes in the hamstrings, or they can suddenly become very crouched because the hip flexors can really go tight with the growth spurt. So again, use those action acronym, which I talked about in the slides, as your indicators. So if any of those functional problems functional activities are a problem, then it's likely that with growth spurt, things are changing because their bodies are constantly changing, and the system is really got to go at the same pace as the body changes, which is quite hard when you have impact with the neurological injury. So so it's important to understand that concept, and as long as you raise and understand and are aware of where it's coming from, then yes, you can raise a concern and we're there to help you.
Yeah, absolutely. I think that issue of growth spurts is a really important one to explore. I know as as the mum of a 14-year-old boy who has grown, I think we're up to about 10 centimetres now in this lockdown period. He has no idea where his limbs start or end, and we're seeing that kind of that almost elasticity in his movements at the moment, and I think that's something, as you say, that needs to be monitored and managed throughout. A question has come through from one of our live listeners, and this may take a little bit of time to unpick. So you haven't given your name, but if you could just drop me an email or a message so I know who you are, we can get back to you. But the message is this, Kay. What about if the child is looking down all the time and is not face to face? Would this suggest that there is a problem with the neck area? And if so, is physiotherapy recommended for neck exercises?
So if the child is, it's interesting, I would like to know a bit more information really about this. So if a child is not looking up and looking down and is not face to face, are they struggling with eye contact? What is the problem that they're looking down is important to establish, because sometimes children struggle to give eye contact because of various reasons. They don't like the physical contact, and they don't like to they find it difficult to visually, and they're sometimes the focus and attention is quite difficult if they have underlying vestibular problems. So we need to investigate what is the reason for them not to give eye contact, and whether or not it's a neck problem or not, it needs to be established. It's likely that it's some other cause.
Yeah, absolutely. And if that person could get in touch and perhaps fill us in with a few more details, we may be able to give some more specific advice. But I think you are right to mention the fact that there could be numerous factors that would give rise to a child not wanting to have eye contact or to be face to face, or indeed to look down, and we need to establish whether it is physiological, neurological, or a behavioural or emotional response to their experiences.
Absolutely. Yeah.
One final question, because I'm conscious that we're nearly out of time, but this is one that really kind of fits in with where we are with the return to school, and the question just says, my child is beginning school in September. Any general advice as to how I approach their physiotherapy needs?
Yes, that's a good question. I think what is important if your child is starting school is particularly based on what their needs are, of course. If they are starting school, most important thing is to make sure, review their equipment, what equipment they are using in school, more from the physiotherapy point of view, whether they are using a standing frame at school, whether they're using a postural seating at school, whether they're using a walking frame at school, what are they using at school, even orthotics, are they using insoles, are they using arm splints, hand splints, AFOs, ankle foot orthosis, whatever they're using. It's important to understand that this is the time you would need a review, because given the fact a child has not gone to school for 6 months and they are now going to school, it's extremely likely that majority of the children had a growth spurt during that time, and those equipment will not be fit for purpose if they were not reviewed by your therapist. So call out to your therapist, make sure that they go in and they set up the equipment, because if a child is starting to use an equipment that they've outgrown, it can cause musculoskeletal injuries. It can cause undue pressure. It can cause them pain and discomfort. Obviously, we do not want any of that. If your child's equipment is reviewed by your community physiotherapy team, by the NHS, this is the time to get in touch with them and make sure that you advise them that my child is starting school. Can you please make arrangement to review their equipment, because very likely they would need a full look at how they're positioned.
Yeah, absolutely. And I think just on that, if we think back to the end of March when we were all suddenly thrown into lockdown, I think there will be questions for lots of schools and families. Where is the equipment? Because has it been put away in a cupboard? Has it been taken back to hospital depots for deep cleaning? So regardless of whether or not it fits first of all, I think the big question is, where is it? Can we locate it? What are they going to need? And all of that needs to be taken into consideration as part of that in-depth review for that child to go back into school and for their physiotherapy needs to be being met fully.
Definitely. The other thing that I would like to highlight is insoles and orthotics. Now, quite often insoles are actually placed within the shoe, and we don't take the insoles out and actually see. A lot of the children during this phase, they've obviously outgrown their insoles, and the toes are obviously going to the edge of the insole, if you like. But the problem is the biomechanical alignment, because if they have actually gone 2 sizes shoe up and you're using the same insole, the arch where you used to sit, which is actually maintains your biomechanical alignment of your body and your posture, your knees, hips, ankles, all linked. That arch actually and that elevation has moved forward because your child is grown. Now, if that is the case, it will have significant impact on how they mobilize, how they walk. So please take the insoles out of the shoe, make your child stand on the insoles and see what the insole is doing. See how much is the gap. You would know whether you would call for a review.
Yeah, really good advice there, Kay. Thank you so much. Unfortunately, we are out of time. Time seems to fly on these webinars. There's always so much content to get through. But thank you again to Kay for joining us this afternoon. I'm sure many of you will be in touch with either myself or with her with follow-up questions over the next few days and weeks. Just a quick reminder that you have already been sent, you should see it on the screen now, the short feedback questionnaire. I would ask that you complete that if you have the time. It really does help us to understand the common areas of concern, queries that are being raised by families, and what support we can continue to offer whilst we are delivering online content in this way. And you will also see on screen the Irwin Mitchell coronavirus update page. And this again is something that I would highly recommend that you put into your favourites on your toolbars for all updates that may be relevant to you and your family, not just in terms of therapy needs, but also in terms of educational needs and legal support as well. And that's updated throughout the week, multiple times a day, quite often. So a final reminder from me that there is still the opportunity to join us on the last episode in this mini series, which will be on the 10th of September. That's actually an evening session, so 7 p.m. till 8 p.m. with my colleague James Betts, where we will look at the updated information with regard to education and healthcare plans. But that's it from me for today. Thank you very much for joining us. Thank you, Kay. I hope we get to see you on screen again very soon.
Been a pleasure. Thank you.
And a very good afternoon to everybody. Take care.
Thank you.